At 7:30, and I think Dr. Feldman's on and everybody else is on as well. So I think we're ready to go. David, are you okay on your end?
Yes, Kevin, good to go, thanks.
Yeah, okay, good. So welcome to Surgical Ground Rounds again for 2022 edition. It's my pleasure to welcome Dr. David Buckeridge, Senior Scientist from the Research Institute and Professor of Medicine in the Division of Clinical Epidemiology. David's particular background, I don't know, David, what is your MD training in? What's your clinical specialty?
Public health and preventive medicine.
Okay, great. And so Dr. Buckeridge has been really seminal in trying to put together the MUHC data warehouse, and big data is the talk in the last couple of years and going forward as well. And we've noticed in COVID that it's important to have good data and be able to transmit the data, have access to the data, and actually interpret the data. So there's a lot of steps there. And when I first learned about the MUHC data warehouse, I thought, wow, great, what a fantastic operation and what a fantastic idea. But it's become a little bit of a mystery to me. And I thank David for coming and trying to explain what it is, what it can do, and maybe hopefully how we can access it in the future. So David, thank you very much, and welcome to Ground Rounds.
Great, thank you very much, Kevin. And I'll try to demystify that and hopefully place the data warehouse in a larger context in terms of where we're going with access to data here at the MUHC. So I'll just share my screen here. Oh, there we go. Interesting. There we go. You're seeing it now, not quite in presentation mode, but there you go.
We see. Yeah, that's perfect.
Okay, yeah. Great. So I've entitled this talk, Enabling a Data-Driven Future at the MUHC, Some Opportunities and Challenges. 3 parts, as I mentioned. First, I'll give a little bit of background, which may be review for some people, about the steps you really need to take in general to make clinical data or data from clinical systems useful. Then I'll spend most of the talk focusing, as you mentioned, Kevin, on the data warehouse at MUHC, how it came to be, what's in there, and most importantly, how you get access to it and do research with it. And then I'll spend a few minutes towards the end of the talk on the future of data at the MUHC. So where are we going from the warehouse and what are the next steps? So first of all, making data useful. Some of you may have seen this image before. It's intentionally structured to look a bit like an iceberg, but every column is a patient showing data from a patient. So the green is what you might get from claims data, the kind of thing that we usually operate with when we do health services research, coming from the RAMQ, MedEcho, that sort of thing. And then the brown are meant to show sort of the underground part are really what come from the clinical information systems in hospitals and to some extent primary care, but mainly in hospitals. And what's trying to show is the depth of that data. So pointing out that, for a given patient, there's an order, probably 2 or 3 times, if not more, data available on them from these clinical information systems that we get from sort of routine reporting through claims data. And this is actually a dated slide. This is from 2015. So this has increased even more. So obviously these data, which are collected primarily really for delivering clinical care services, can be used secondarily for other purposes. And we can think of examples here. I'm showing 4 elements of the MUHC mission here: clinical care, technology, assessment, teaching, and research. These data can be used for all of these things. And this isn't new. We've known for some time that what the information or data we gather when we deliver clinical care is useful for those sorts of things. What's changed in the last 20 years, though, is the proliferation of these systems that emit lots and lots of data. So before, we used to have to go and review charts and so on, or do studies and talk to patients if we wanted to get those data. We can still do those things for certain types of studies, but there's vast amounts of data being pumped out by these systems, and even more if we think about systems outside of hospitals, for example. And in the last 5-10 years, the rate of the emission of these data, the volume, variety, velocity, which are the terms used to really describe big data, has really ramped up. And that has had an influence on how we should be able to collect these data and what we can do with them. The opportunities really have grown. So, sorry, I'm skipping ahead a bit, but so that's the good news. The challenge, though, of course, is that the data are not useful exactly in that format when they sit in those systems. So, as all of you know from as they're practicing clinicians, the data are really in these systems that are optimized or designed to support the entry of data and the care of individual patients. So think of our lab system, our radiology system, the operating room system. They're really mainly about data inputs and managing the care of one patient. And it's generally not easy to extract data from many or all patients, as you might want to do for teaching or for research, or a large subset of patients. And that's for a number of reasons. Some of it has to do with vendors not wanting to share those data and the value of those data, but that is slowly changing. But nonetheless, to enable the use of those data for secondary uses like I described, we have to do some things with them. We first of all have to extract those data from the source systems, and there are different ways of going about that. We then have to restructure and harmonize those data so that they look somewhat similar, and then we have to link them together across patients usually, or episodes of care. And then they have to be cleaned so that we have high quality data. And then the last step is, of course, we need to take that data then and make it available to people who want to do research with it or use it for other purposes with appropriate supports. So those steps are not trivial, and it's possible to do that one project at a time if you'd like, but that's really not efficient, particularly not for an organization the size of the MUHC. So you really want to think about how can we do this kind of extraction, organization, making these data available in an ongoing way as a resource for what we want to do those secondary kind of applications within the hospital. So this, of course, is not new. As I mentioned about maybe 20 years ago, at the turn of the millennium, we saw the beginnings really of efforts to put in place infrastructures that routinely pulled data from these clinical systems and put them in a format where they could be used. And this was really driven primarily in the late 1990s by US health maintenance organizations, large academic health centers that were really trying to understand how to get value out of healthcare. And so they really need to understand what was happening. And so they needed those data. And that early work, some of that done just in Boston at Mass General Hospital, for example, when they put in a data warehouse, they found that within 3 years, they were generating $20 to $30 million in research grants just using those data that they didn't have in the past. Other studies have also shown that having data warehouse in place can facilitate and really increase enrollment in clinical trials or other methods. So there's not a lot of really hard evidence, I would say here. There is some really, some evidence in the literature. And more generally, this is a movement across multiple industries, not just healthcare, that you need to get your data together. And then this is essentially the way to go about it. If we want to get a bit more into the kind of information technology, and I won't do too much discussion of that in this talk, but I think this is sort of an important perspective to understand and where we're going at the MUHC, that there are different approaches to, once you get the data out of the systems, where do you put it and how do you manage it? The more sort of well understood approach is what's called data warehousing, which is really just a large database that you put the data into when it's linked together. And we use standard sort of tools to interact with a data warehouse, namely SQL, which is a programming language, structured query language, but it's fairly well understood. And this approach really works well for what we call structured data, where you have variables like counts and codes that fit into tables. And because it's been around for a long time, we have lots of well understood technology and mature infrastructure, including things like you may have heard of I2B2 or the OMOP Common Data Model. These are tools developed by our colleagues in the US to really help manage these kinds of large clinical data warehouses. And this approach is really best when you kind of know what the data are going to be used for a priori, like you're doing reporting, or you're really, as I said, working with structured data. The new strategy that's emerged more recently is something called a data lake. And a data lake is really just a big folder like you would have on your hard drive in some sense, where the idea is you just throw the data in there. You don't do a lot of transformation. You don't try and think about how it's going to fit together ahead of time, and you don't really try and integrate it. So the data is a little, I would say, more raw. And in that case, you need really data science tools to interact with it. So things like Python, R, these are programming languages you may have heard about, but it requires a different kind of skill set, if you will, to interact with those data. The advantage of this approach is it can really take any kind of data. So, high volume, including streaming data, video data. So the kinds of data you couldn't really stick in a database with a data warehouse approach. The challenge here, of course, it's an evolving technology. You're a bit at the bleeding edge, although not, I would say, bleeding, more cutting edge these days. There's been some experience in other domains about how to do this well. And this approach to data lake is really best used when you don't know a priori what you're going to do with the data, or as I mentioned, you really have a lot of non-structured or streaming data. Now, of course, the truth of what really works the best is somewhere in between, is what the reality is starting to show. And so these hybrid approaches where you would have a data lake to kind of catch all your data, do some experimentation with new data sets, but then ultimately you put the data you really know well, like your claims data and so into a warehouse, is really the way things are going. And as I mentioned, because people have been at this for about 20 years, there is actually a fair bit of literature on clinical data warehousing, not necessarily the return on investment, but the how to go about doing it. So this is a diagram from a recent systematic review of academic health centers that have published their experiences on clinical data warehouses, just showing that they tend to converge really on different types of architectures, often driven by the organization and the orientation that led to the development of the warehouse. So the diagram on the right is showing you in the colored strip, essentially, with the labels on the left, the names, and don't worry about the names, you might recognize some of those as organizations like Vanderbilt and Mayo and so on. But what it's showing there is the architecture type with the key on the bottom right, and then showing the types of data in each column, with gray being they have those data. So they all have EHR data. But some, as you can see, are a little more focused around biobanks. Others are focused more around federated architecture, which means that they have multiple sites. They don't just have one site, and they want to be able to query across multiple sites. But this review also found common features, like, for example, as I mentioned, is putting them all in the same language. The data from the different systems is really important, and having common standards. So just to say, there's a real, I think there is a lot of evidence here to help us understand where to go in the work that we're doing at the MUHC. So that's a bit of background on where the data come from in healthcare establishments like the MUHC, and why it's important to do additional work to make those data useful. So now let's focus specifically on what's happened at MUHC with the data warehouse. So the origin data warehouse, we have to rewind a bit. I was showing you that systematic review from now. We started this some time ago, and I'll show you the timeline in a second. It was a coordinated effort between really four groups. The MUHC, led primarily by the DQEPE, but other groups were involved. The RI-MUHC, my research group, along with Robin Tamblin and others, the McGill Clinical and Health Informatics Group, and then Logibek, who was the vendor. And it was really funded by two sources. One, the CFI award, the large CFI award that helped to really build the research institute at the New Glen, and also the hospital put funds in. And there was considerable learning along the way. So we started this, as I will show you on the next slide, around 2015. So there was evidence out there, but we didn't have a lot of experience with this approach at the MUHC. So in the first phase, we had the CFI funding and the money from the hospital, and we had this procurement vehicle available with Logibek that allowed us to go into the process of building or procuring and building the infrastructure, which we thought was going to be the hard part. And it turns out that was actually the easiest part. I wouldn't say it's easy, but it was the first step. So we built the infrastructure. We then moved ahead to look at what that meant for governance and operations. So as you could imagine, prior to the warehouse, the way to get data was to visit every source system and try to extract data from the systems one at a time, take it back to your research lab and do something with it. So there really wasn't a well-established governance for how people access data through some sort of centralized source like a warehouse. So that had to be put in place. We had to coordinate with the Research Ethics Board in terms of ethics review and how that relates to access to data from the warehouse. We then went into another phase of having to sort of look more closely at policies and operations, refine those, get approval from different levels of administration at the MUHC, and finally became operational in 2019. So it took us about 4 to 5 years from start to finish. Then we went into this movement of having a bit of a think tank at the MUHC just prior to the pandemic on digital health, which really helped to, again, place the data warehouse a bit in the perspective of where we want to go at the MUHC. And then more recently, the Research Institute has hired a new director of informatics and IT. He's been there for just over a year now. And he started to really rethink the RI's research informatics strategy to align with the warehouse and really build up the operations on the research side around the warehouse. So it's been a long and ongoing journey. And as I said, lots of learning there in terms of both the sort of the technology, the data, the people, the governance and policies of the MUHC. And as an organization, I think we've come a long way, but there's still farther to go. So what's in the actual warehouse? These are the source systems from the MUHC that are read into the warehouse. The dates indicate the date for which data are first available. So you can see that sort of central column where I say domain and available. Those are all the data systems that are currently in the warehouse. The ones in the far right column are sort of in a queue to be added as resources permit or projects require. So it really has the main sort of core systems, infection, imaging. ADT is the sort of the system that monitors where people are in the hospital, laboratory, pharmacy, emergency operating room. So really a lot of data about an inpatient stay. And again, these are not necessarily just codes that are entered. This is extracting all data that's relevant really from these systems that might be used for research or quality performance or other applications that I showed before. So how does the data get from those systems to researchers? I'm showing you a bit of a schematic here on the left. You can see these source systems. So each one of those, I'm showing 4, but obviously there's 30 odd systems in the warehouse right now, and there are hundreds that we could possibly tap into. And there's 2 main ways they get into the warehouse. One is that we actually put a little database behind the system, and then we query the system once a day and pull the data from that system into that little database. It's called the operational data store. And then that's sent on to the warehouse. The other approach for systems that don't let us access the database, for example, the Cerner lab system, we actually just catch the messages as they come out of the system. So as I mentioned, each of these systems is really used for routine care. And so every time somebody does something in the system, like makes an order or does changes a value, that creates essentially a message that comes out of the system and goes to kind of a router in the hospital called the interface engine. And we use that to catch those messages and they go into the warehouse. So just to say that we're a little bit, we have different approaches to pull data out of systems, but ultimately they all get pushed into that large database, which is the enterprise data warehouse. We do a little bit of that reformatting and restructuring I mentioned. And then when researchers are granted access, a data extract is pulled from the warehouse. So there's a team that actually does queries against that, pulls out the data you request, puts it into an internal kind of cloud server called Nextcloud, and gives you essentially the access to that. And then you can pull that down into your research systems within the Research Institute or the hospital. So that's the overall flow for how data goes from the source systems to researchers. How are those data organized and like what's really there? So this is a little bit dated in terms of the numbers, but the high level schema is shown on the left. You can't really read all the details, but what it's showing you is that centrally it's all organized around a patient in an episode of care. So we take data from all of these systems and we link them to episodes of care, which means if you went to the ED and then went to the ward, then to the operating room, for example, all those records will be linked into one episode. And then moreover, they're all linked back to the patient as well. So that you can really query by patients with certain types of conditions and pull out all of the records associated with them that you need from the different source systems. The pie chart's just showing you the distribution or breakdown in terms of where the data are coming from, which are the source systems by the number of rows. So that the majority of the data are from the lab, but the other data systems also generate a fair bit. And as I mentioned, this is somewhat out of date now. This is from a few years ago. So we definitely have more data than this in the warehouse, but this should give you a sense of kind of the rough breakdown. So more mechanically, how do you get access to this? So if you're starting a research project or you want to start a research project, how do you get data out of the data warehouse? Well, the flow diagram on the right is sort of showing you the idealized schema here of how things ought to work. And on the left, what I'm showing you is the MUHC RI portal. So the portal is the place to go. If you want more information, you can see it's just portal RI-MUHC.ca. You want to go to the research tab at the top, and you want to click on the left side there on MUHC data warehouse. So research up here, and here's the MUHC data warehouse. That'll bring you to this page here, which tells you how to request data from the data warehouse. And so you'll basically be going through this flow chart here once you get there. So there's two ways to trigger this process. One is you can do what's called an IT rescue ticket here, where you basically send in a request and you say, either I'd like to get some counts on patients. I don't want data, I just want counts, or I want more information. I'm not quite sure if what I want's in the warehouse, I want to interact with a human. Then you create this IT rescue ticket, and one of the data warehouse analysts in the Research Institute will get back to you and will ask you exactly what you want, and you'll have a back and forth. And that's a really good way to start to explore what's in there, determine if the warehouse really has the data that you need, and if your research project is a good fit. As I mentioned, it's also if you're preparing a research grant and you want to know, for example, are there enough people with this disease or had this procedure, they can run those queries for you in the background, and they can give you those numbers. That does not require ethics approval, and that can be done ahead of time to sort of give you the if you will, the background you need to request funds to do the project. The usual way to get that the access is triggered, though, is by actually putting in a request to Nagano. So when you put in a request to Nagano for REB approval at the MUHC, and you indicate, pardon me, on Nagano that you want to use data from the warehouse, that will trigger the data warehouse team to, first of all, they'll receive that request and they'll analyze your requirements and they'll determine, are the data actually in the warehouse? If not, they'll let you know and close the request. If they are, then they go through this process that's linked to the Nagano process to authorize your access. They then go actually and build the data, as I mentioned, send it to Nextcloud, and it'll be sent to you. So I wouldn't worry about the details of the flow chart. The main point is to know that to get into the warehouse, you need to go to the portal. You can either send this IT rescue request to talk to a human, or you can start your REB process, and that will trigger an interaction with the data warehouse team. So that's the indoor. How are things being managed? So this is data that's been shared from the RI-MUHC data warehouse team, showing you the total number of requests, as you can see in purple, increasing, the number that have been closed, which means they're either completed or not addressed because they weren't relevant. And then you can see the to do and waiting and completed. So clearly there's a gap between total and completed, and you can see there's a lot that are closed without being done. What the good news is that we've seen this drop here in to do and waiting lately. And that's because there's been two things, I would say. One, as I mentioned, the new director of informatics IT at the RI has really done an excellent job putting in place efforts to improve the process of access and also increase staffing. So what do, no, sorry, my slides are frozen. 1 second. Yeah, here we go. So why would people be waiting, and why would requests not be processed? So of all the requests you saw, if you start in the bottom right here, you can see this chart showing you the large number evaluated not proceeded are from people that made a request and either did not respond when the data warehouse team got back to them, or when they reviewed it, it was found to be the data weren't in the warehouse, for example, or they wanted to do something that was really beyond the warehouse. It was more about interacting with information systems. So this speaks to the need for much better communication. As you pointed out, Kevin, you were in the dark. And so I think there needs to be more of a communication strategy. And that's certainly part of what they're working on at the Research Institute, to notify people what's in the warehouse, what it's good for, to really try to maybe preempt some of these requests that are not well suited to the warehouse and increase the number of requests that are well suited. So of those that are waiting, why are they waiting? That's this large pie chart showing here over to the left. And the main reasons that people are waiting in this queue are essentially on the side of the PI. So it's really not so much on the side of the data warehouse team from the analysis. It's waiting for the PI to fill out the intake forms. You do have to fill out a series of forms that correspond to, the ethics forms you'd fill out. Why do you want the data? What are you gonna do with it? That kind of thing. And then you have to specify exactly which data you want. And this is a challenging process, which I'll come back to, but it requires some clarity about exactly what you want to do with the data. You have to understand what data is in the data warehouse. And then there's a bit of a back and forth process. So there's a lot of back and forth. And so this is really what takes time. The good news is once those requirements are done and it's clear exactly what data you want, the data warehouse team is usually able to return a data set to people within 1 to 2 months. And so the timeline is actually not bad right now. And on the MUHC side, to actually extract data from the warehouse, there's really no delay right now. So what kind of research projects are people doing with these data? the pie chart on the right chart breaks it down into these higher level bins of clinical, data bank, retrospective, and mixed. I would say one large area is the feasibility assessment, which is not shown in the pie chart on the right. That's, as I mentioned, those aggregate counts. So where you just request to get a count of people with certain conditions over a certain interval that you'd want to use for your planning your research activities. Clinical trials are most often where people come with a patient list or ask for help with patient recruitment. And it's used to really recruit subjects that match a certain characteristic or to pull data for patients for whom you already have consent and are in a trial. The retrospective cohorts, exactly as it said, is really for you've got a type of patient you want to collect all data for that type of patient over some historical interval, and you want to do some epidemiologic study or risk prediction of some sort. The data bank is a bit different, and I'll give you an example of that in a second. But a data bank is really where you want to set up almost a research registry. So you have a kind of a type of patient you want, and you want to follow that type of patient and those individual patients over time. You can then make a request to the warehouse to pull data for those patients that meet that criteria and to get updates on those patients and even new patients that match those criteria as you go forward in time. And so it's a bit kind of like a cohort, but really it's sort of an open cohort that you're asking the warehouse team to give you data for in an ongoing way. So those are the kinds of research projects. You can see the breakdown. Over half of the projects that have been done so far have been retrospective, but there have been some clinical trials and data banks supported by the warehouse. Okay, so an example of a kind of research done. So this is a project that I've been leading at the MUHC. It's a multi-centered study led out of the CHUM, but has hospitals across Quebec participating. And so this is an example of a data bank from the last slide I mentioned. So what we want to do is create a data bank of all patients who were tested for SARS-CoV-2 at the MUHC. So it starts really in January 1st, 2020. We pulled data from approximately 30 different systems that are relevant for these patients. And the intent here of this data bank is to support research on diagnosis, clinical phenotypes, early warning, and healthcare resource utilization. We're also using this data bank as a foundation for generating synthetic data for teaching. So as I mentioned, not just research, but also teaching is a allowable or I think a positive use of these types of data. And the extract was provided to us as multiple tables, as I mentioned, through that secure cloud. So this is just to give you a sense of the kind of the magnitude and type of data that will be made available to you to make a request. So here you're seeing all the different tables that were pulled that came to us as a series of different data files. And then we have software engineer in our team actually pull them together into a data schema that is shown here that allowed us to organize the data and do our research with the data. So continuing with that same example, because it's a data bank, there are two ways to access it. One is directly from within the data bank. So for MUHC researchers, it's really just sort of another database with a subset of the whole data warehouse. And so MUHC investigators can approach myself or others who are on the investigator team and ask for access, would then make an REB approval and will be granted access, and they would then be able to access those data for research if it's consistent with our the plan, the intent of the data bank. And the other kind of interesting way that people can access these data is through federated systems. So the actual grant, the multi-center grant I mentioned, is around federated machine learning. And so the idea here is that multiple hospitals in Quebec will pull exactly the same data from their systems, structure it the same way, and then sort of expose it, if you will, for a central computer system to come and analyze the data at each site, but then only centralize the results. So the idea is you don't pool the data, you leave the data at every hospital, but you allow your algorithm to go visit the data at every hospital and perform an analysis that is almost like a meta-analysis and gets pooled in the center. And so those are the two ways that the data can be accessed, either directly through this data bank or programmatically through this computer system we set up at the Research Institute that allows other investigators to query against the data. And we can do the same against their data sets as well. Some of the challenges encountered in this project, as I mentioned, there were some delays. We made this request at the start of 2020 when there was a considerable backlog that since improved with the warehouse, but we did have some delays. I showed you on that previous slide, we received many large tables, and so we did require people with expertise in software engineering and data science to sort of structure those tables and put them together. there are many coding systems used. So, and I'll come back to that in a second, but every clinical system to some extent uses a different terminology or a way to record the data. You can think of it as a language almost. And when you pull those all together, then you have a whole bunch of languages and you'd like to harmonize those. That's not really well done or completely done in the warehouse right now. So it's sort of an exercise for the user to some extent. And then you have to validate that data extraction. So, it took us some time to go back and we had a few back and forths to make sure we were getting the right data. And perhaps one of the most challenging pieces is really understanding when you get that large amount of data about those patients, what are the clinical and system processes that generated the data? And so what I'm showing you on the right is a bit of a sort of stylized Venn diagram that's really different versions of the truth. So we were trying to estimate, of course, how many patients have COVID-19 were diagnosed as positive because our cohort is people who were tested. And it really depends on which variable you look at. So the green, the green is a lab result. So that means they have in our lab system a positive PCR test result. The red means they have an emergency room code, emergency department code suggesting they have COVID-19. The yellow is the ICD-10 code at discharge for primary COVID, and then blue and orange are secondary COVID. So as you can see, it sort of depends, how you define this, how many patients really have COVID. And this could be, in other examples, you talk about breast cancer, you might get the same map as well. And this doesn't mean necessarily that things are a mess and we don't know what's going on. It just means that it really depends which system you look at, you'll get different numbers. And so this speaks to the need as an organization to have better harmonization across these terminologies and a better conceptual clarity about what we're calling a COVID case or what we're calling, for example, a case of breast cancer, so that when someone asks us how many we have, we can make a query against the data and get a number that's consistent. And that's something I'll come back to in a second. So just after that example, just to reflect a little bit on where we are at the warehouse, what are the challenges in providing data in this way? So as I mentioned before, one of the biggest challenges is turning a research question into an actual query against this large data warehouse. So researchers have difficulty, and this is not a fault of the researchers, in specifying exactly what they want. So you have a hypothesis, you have a study design, you know what you want to do, you know conceptually what data you want, but to get the data out of the warehouse, you have to exactly specify which tables, which fields you want to pull those data from. And it's that last portion that's really quite challenging. So what can we do about that? We need better documentation. Obviously, if there was a very well-detailed data dictionary, we do have a data dictionary that you can get access to through the portal, but it could be better and it could be clearer. The analysts know the data at the warehouse that work with the researchers, but they could get a deeper understanding. And also we could have self-service tools. So researchers could really just access the warehouse, not the data directly, but start to query against it and just see the counts and get a sense of what's there in a privacy preserving way. The second issue is generally speaking, depending on the type of research you're doing and the kinds of questions you ask of the warehouse, you can get vast amounts of data, which may be exactly what you want if you're trying to do a machine learning study, but it is a lot of data. They're going to come from multiple systems that haven't been really fully integrated. And so it takes time to manage those data once you receive them and get them ready for the research and do the research. So here you really need dedicated analysts and a quality assurance plan. Some of that should be done probably more on the warehouse centrally, but there is some work that has to be done by the researcher. And the last piece, which the Tower of Babel image sort of speaks to, is, as I mentioned, there really are many coding systems used, and there's no single lingua franca. And this goes back to, if you recall, when I was the first part of the talk, when I was saying about that review of different clinical data repositories, one of the things I found to be important was the use of a common data model and these standard terminologies. And so this is an area where we're working towards the MUHC, but it's a lot of work. It really takes effort to look into these systems, understand the terminologies, and map them to some common data model. It requires clinical expertise as well as data expertise. Okay, so that's the data warehouse. Now, the last part of the talk, I just want to say a little bit about the future of data at the MUHC. Where are we going? So I think this is a theory that you may have heard of, learning health system, a framework or a theory that really has resonated quite deeply with people in informatics, in health services research, in a lot of areas. And it describes, it's not an entirely novel concept. You could think of quality improvement cycles and so on, but it casts it in a very useful frame that I think is very helpful from a clinical perspective, an operational perspective, and a data perspective. And so what does this theory say? It says that we want to really create and empower within any healthcare system, including a hospital, what's called a learning health system. And what does that mean? It's described as these cycles that may happen. So a learning health system is a system that is continually doing these cycles at different levels of resolution, and different scales, you might say. And it's broken down into these steps. So the first thing you would have is when you think about doing something in a day-to-day way in clinical care, you're actually generating data. These are the primary data I mentioned at the start of my talk. And you can think about that as some sort of performance. I don't mean necessarily performance in an optimal sense, just you're performing something, although you can think about optimizing it, and that's generating data. Those are the primary data. What we want to be able to do is capture those data. And then the next step is to say, how do we take those data? How do we turn that data into knowledge? And so data here are these facts we're measuring about the world. Some degree of analysis and contextualization is required to understand or derive inference or meaning from those data. And so this is the data to knowledge step. Then once you've done that process, you've analyzed the data. So if you think about this as a clinical, sort of procedure you're performing, you're analyzing the data about the procedure, the time, the types of patients, and so on, trying to identify patterns, opportunities for improvement. You glean some knowledge out of that. You want to be able to take that knowledge and push it back into the system to improve performance. This could be through redesign of a process, through decision support, but you want this cycle to go around. Now, and so this is, as I said, happening at different levels. Ideally, you've got a community, not just one person doing this, so that they're internalizing this process and the findings from it. But as I said, here I'm showing on the right now those three steps: performance to data, data to knowledge, and knowledge to performance. If we think about this from a digital infrastructure perspective, there are clearly some digital infrastructure requirements to do these steps. Performance to data, we have to capture that data. We have to capture not just, simple data, but perhaps video data. We have to capture other types of data. And it should be done in a way that's relatively seamless and relatively low effort on the part of the clinician. So, may have made some progress towards that, but I think there's a lot of room to go at the MUHC in terms of this type of data capture. If you want to turn that data into knowledge, obviously you need a place to put the data and you need the capacity to analyze it. And you want to do this fairly quickly. You don't want very long delays if you want to be data driven. So that's something where we do need a lot of work at the MUHC. We're not, the warehouse is, as I would say, a bit of an offline strategy for that, but ideally we're doing this more quickly. And then finally, the knowledge to performance piece. How do you get that new knowledge you've derived from analyzing that data back into improving your process? Well, you have to redesign the process. You want to put in place decision support. So how do you make these three things happen in terms of digital infrastructure change? This is where I refer to a sort of second theory that's, I think, been really quite useful in organizing how hospitals have moved forward in this era. And that's something called digital transformation. So I'm sure you've probably all heard of digital health, which is defined as the use of digital technologies to produce or deliver a healthcare product or service. In that context, digital transformation is the concerted and coordinated effort to incorporate digital health within a healthcare organization or system. So it's not just, trying to use more digital health tools here and there. It's really thinking systematically about how are we doing care, teaching, or other aspects of our mission, and understanding what those processes are and how we can get digital health in there to optimize those processes. So the idea really is to try and reimagine how we do things and make best use of digital health technologies to do them more efficiently, more effectively, and not merely just to automate the process, not merely do the manual steps faster. Sometimes that is the way to go, but often we can get much larger efficiencies if we rethink what we're trying to do, which obviously requires deep domain knowledge, and we use these digital health services to do it better. So the focus then has to remain on improving the service, not the technology. And the good news, not unlike with the data warehouse experience, is there are other organizations that are certainly outside of healthcare that have been have shown success in this area of digital transformation. And there are a number of key points for success, which I'm pointing there. Many of those exist at the MUHC now, and others we're working on putting into place. So specifically at the MUHC, how is digital transformation? What does it mean? We had a series of consultations in last summer around digital transformation, mainly with patients and administrative and clinical leadership at the MUHC. And that showed strong support for this kind of a transformation process where we really try and think broadly, and we try and move forward with incorporating these different digital tools in a way that improves our care and administrative and teaching processes. We're in the point now of working on developing a sort of strategy and a roadmap, informed to some extent by those consultations. Also aligning that with the MUHC strategic planning, which is ongoing, and coordinating with the MSSS planning. They are also supportive of this sort of framing and this movement in expectation of changes that will occur with provincial information systems in the coming years. And the RI-MUHC and McGill are also, as you might imagine, moving in the same direction, and so we're coordinating with them. And this is work that will roll out over the next few months. It's obviously, like everything else, been a bit slowed by the pandemic, but we're expecting this will pick up into the spring and summer. While that planning and strategy and roadmap development is underway, we're also have a number of activities in this space. One is to support some key initiatives, and I'll just say a couple words about that. One initiative, which is using AI to support OR scheduling, which I think will be of interest to people here. And the second is advancing data management and analytics. So the first key project, I think is a really good example of digital transformation potential here, is optimizing surgery scheduling. So this is a $1.5 million federal grant from a group called Scale AI to the MUHC, and I'm delighted to say it was just finally finalized last night. So I received the email that the grant has been signed off by Scale AI, and the project is actually underway now. Well, we're sort of slowly getting off the ground, but we'll really kick off, I think, with speed in February, and it'll go through to August of 2022. And the goal is to develop AI-supported software for optimizing surgery scheduling at the MUHC. It's really an example of, as I mentioned, this sort of thinking about, let's think about how we can redo the process using digital tools to some extent, but really driven by clinical leadership and clinical problems. And so there's been great leadership from the Department of Surgery, and also from people in the MUHC administration. And I think this is really, as I mentioned, or if you recall from the previous slide I showed you, digital transformation, one of the success factors was working across organizational structures. So being able to pull together teams across different parts of the organization is really key to doing these kinds of projects. Also, it's allowing us to interact with partners. We have subcontracts with Avado Labs, which is responsible for the AI expertise and software development, and with other organizations like Precision Analytics, which is a data science consultancy. So this project, in addition to being able to explore the potential of AI for optimizing surgery scheduling, also gives us the opportunity within the digital transformation context to pilot approaches to data management and analysis and working with external partners. So I think it's a really important example of a project in this space moving forward. Oops. So just at a very high level, I won't say much about this, and I'll leave it to Drs. Feldman and Tanzer to perhaps say more in a subsequent grand rounds in the future sometime. But the idea really is, as you might imagine, to try to really optimize or do the best job of using the time available and the resources available in the operating rooms. And so that requires data, primarily from the operating room system, and then software will be rewritten to try to find that sort of the best schedule that would make the best use of that operating room and the resources associated with it. But it's not just about the data from the operating room system. You also need to understand something about how long operations are likely to last. And so they'll be also working on some machine learning to predict this, also to predict the availability of beds. So, is there a space available for these patients if they are to have a procedure? And also look at new unplanned surgeries coming in. So that's sort of the back end, a series of machine learning models tied into software that would also have some sort of optimizer for the planning, and then these different interfaces that would be put forward in front of the teams that exist in central OR booking to manage the scheduling. And at the bottom here, well, hopefully there'll be resources available to also create a bit of a what-if model. So once all this is done, you can use it to sort of plan a schedule, of course, but you can also use it to say, well, what if we tried different changes to, the way we do things now? What would be the benefit to the surgeons? What would be the benefit to the optimization of the resources? And so the bottom part here is meant to be a little bit more of an offline, but kind of exploratory component of the project. So anyway, that's just getting started. I'm sure you'll hear more about that in the coming months. I'd just like to close then with just a few words about advancing data management and analytics. So as I mentioned, this is really a critical component of everything that we do. We want to do this in a good way centrally, because the more that's done centrally, the less that has to be done from people that would extract data from the warehouse or other systems. The higher quality the data is. And of course, the faster we can do this, the more rapidly data-driven we'll be as an organization. So we are developing a roadmap specifically around improving this data management and analytics capacity at the MUHC. We had a consultant do an external review in 2021, early 2021. This was somebody who has extensive experience in this area, working with large private sector organizations. That created a foundation for where we'd like to go. We've been talking with peer institutions and engaging with partners like NELA to understand what are the options here. We plan over the next little while to conduct some pilots, not all of this in the context of the project I mentioned, but some of that in this project. So how can we do a better job of working with these kind of streaming data, different data types, more flexible things like data lakes, and how do we bring in expertise in data science and machine learning, not only on a research side, but within the actual hospital operations. And of course, we're coordinating again with RI-MUHC, which is making fairly large investments in enhancing research computing, and also hopefully in advancing their highly qualified personnel to support this kind of work. And also with McGill University, which has put in place a research data management group centrally, and also in the faculty has a steering committee on informatics, is really trying to coordinate their resources in this area. So with that, I'll just summarize, I guess. So far, I've just given you an overview of why it's important to make data useful. So you can't just, there's work that has to be done. There's a lot of data out there, but we need to do some work to make it useful. At the MUHC, we had this experience with the warehouse, which I think was very formative for us. We've learned a lot, but there is more to go. And that future is really one around trying to build a learning health system, think about how digital transformation can help us to get there, supporting key projects like we're doing now, and really ramping up our data management and analytics environment. And with that, I'll stop sharing, Kevin, and pass it back to you.
Thank you very much, David. That's really encompassing talk on the data warehouse, and a lot of answers, a lot of questions as well. And I'm just trying to get my head around everything. But I know there are people that have a lot of questions probably already, and I'm just looking at some of the chat. Maybe people could just put their name in the chat so I could get to them. I know Dr. Freed has a question, and I think some of us had the same question, was how does the MUHC data warehouse link with the RI-MUHC data or other new let's say, provincial databases?
Great question, Dr. Freed. I didn't mention that, but that's really important. And there is good news on that front. So the way people access administrative claims data in Quebec has changed. So it used to be you would go to the RI-MUHC and ask them for data. They give you a data set, you'd take it back to your lab and link it. That no longer happens. Right now, the only way to get access to provincial claims data for research is to make a request to the ISQ, Institut Statistics Quebec, and then you'd have to go to one of their physical guichets, bunkers, I call them, bring your data to them, which means you'd have to bring all the hospital data you want to link with that to them and do that work there. What's happening now is the ISQ is Statistics Quebec is realized that doesn't work terribly well for clinical research. And so they're in the process of putting in place these kind of guichets within academic health centers. So we've started that discussion to have one of those centers put in place at the MUHC. Some other hospitals have already gone this route. Saint Justine and the CHUM are ahead of us to some extent, but the path is fairly clear. We just need some resources to help plan that out. But that would be the plan, is that we would create essentially an environment within the MUHC, which would hold all of the provincial claims data, and researchers could request access to that environment, and then we would essentially push into that environment the clinical data from the MUHC that you could link to those claims data for your research. So I think this will be a real step forward for the kind of research we do, because that would allow you to get essentially all outcomes data on those patients that you might be treating. That's not going to happen tomorrow. There's probably a few months to maybe a year or more of work to get that done, but it's really exciting to see that. And it also intersects with another issue I didn't mention, which is the change in provincial legislation around data access. I won't go down into that, but just to know there is a sort of a trio of laws that have changed in Quebec. Two have already changed. One's a project of law still that will really change the way that we access data. In some ways, will really smooth access to data for research purposes.
Thank you very much. We'll try to we got about 3 or 4 questions. I think I'll let Dr. Feldman, and then Lorenzo, Ferry, Julia, and then Dr. Gilbert. So I'll try to go in that order.
Thanks, Kevin and David. That was an excellent, really great talk. I think we've got really good participation this morning. Obviously, this is a topic that I think really interests everybody, and I'm so grateful for your leadership in helping us get involved in this. I think you wrote that grant in I think a week or something, and then we have to patiently go through all the processes to get it done, and you've really been a great leader for that. So that's really been a pleasure to be involved in that, and we're very excited to start to get that off the ground, as you said. Just wanted to ask, as you mentioned, a streaming video, and I think there are some other questions similar to this in the chat. So streaming video, procedural data, so video, patient sensors, there's lots of examples, and there are people in our department who are very interested in that kind of research. So overall, what's the process do you envision for linking that kind of data that may be collected in the process of individual projects? So how could one envision linking that to the data warehouse?
Great question. Thank you very much, Leanna, and thank you also for your excellent leadership. It's been a really interesting project to get that underway, and it's really benefited from the strong engagement from the department. So I'd say there's 2 paths there. One is if you're doing it as a research project, which is probably the best way to do it first. The second is if you're trying to do it in a more routine way within clinical care processes, right? So within a research project, you would need to capture that data in some kind of a research context. So, you'd have to work with the RI to figure out where you're going to put the data. The challenge, of course, is when you're capturing within a clinical setting in the hospital, that will probably need some coordination with the MUHCIS. So that's where the challenge is. So whether it's through research or operations, we have a very constrained resource there in terms of the hospital information systems team. So, but there are strategies around that. And one is exploring cloud. And so we are looking at more use of sort of commercial cloud, and the ministry does allow that. So for example, you could stream those data to the cloud once that arrangement was sort of blessed, if you will. You would need some link that would allow you to link back to the individual patient, ideally a scrambled identifier of some sort. Then what would happen is you could ask for an extract from the warehouse for those patients. An extract could be then provided to you with a link as well, and you could connect those 2 data sets. So that would happen within a research context. So you would, essentially capture the data in one way, that high modal data, and then you would pull the data from the warehouse and link them back together. It's a little more challenging. We think about doing it as a routine sort of way. If you want to routinely capture video, for example, and push it into that environment, that's where we come back to, the data warehouse is not really made for that kind of thing. And that's why we're experimenting with different central technologies like a data lake. So if we had a data lake in place for the MUHC, you could stream those data directly to that lake, and we could pull it from the lake, connect it to the data from the warehouse, and give you all those data directly. So that's where we want to get to in the next, a couple of years, I would say. But right now, you would have to sort of manage that high volume data in a research context, and then you'd reconnect it with the data out of the warehouse.
Okay, thank you very much. Lorenzo, that was similar? Go ahead, sorry.
Yeah, thanks. Wonderful talk. It's really exciting work. I was really intrigued by one of the first slides you presented, where you had full integration, not only of the data, but also of tissue, of omics, what they're seeing doing in Vanderbilt, which I'm busy next week. And that integration of tissue and video, as Leanne mentioned, Quebec is a very special place, and it requires individual patient consent for some of those things, such as particularly tissue. How are patient consent issues being addressed or at all in the data warehouse, if you are going to start incorporating things that currently requires individual patient consent? Is there implied consent?
No, this is another good question. It goes back to that tree of laws I mentioned. So there are things you can do with patient consent, and there are things you can do without patient consent in terms of data management and research. The challenge, not the challenge, but one thing we have to think about here is that the warehouse is built to serve research, but also to serve hospital operations. So there's also a different, as you know, legal framework for what you do in the context of providing clinical care. So we do not need patient consent to put the data in the warehouse. Essentially, it's just restructuring existing data in a different way. Of course, patient consent does allow you to do certain types of research and use certain types of samples, but in terms of the records that are in the warehouse, you can request access to those data without patient consent. That would require approval of the DPS under the current law. That's going to change in this new law. So the bottom line is we don't currently keep track of patient consent in a centralized way, either in relation to their intent or their consent to use their data in some kind of analysis, or in terms of their consent to be contacted for future research. That is going to have to change under this new law, Bill 19, that's being considered, because patients will have the right to withdraw their consent for certain types of research, even de-identified research using their data. And so we're going to have to keep track of that. I don't know the specifics about how that will change the relationship with biological samples, as you mentioned, but that is an important area certainly to look at. I think, for researchers affiliated with hospitals, this law change should actually smooth things out and make it more transparent and easier what we do both with and without consent. The challenge is going to be for people outside of hospitals, because that's where patients can basically say, I don't want to be contacted by anybody outside the hospital, and I don't want anybody outside the hospital to use my data, even if it's de-identified. So that's, but what the bottom line is, it's going to force the hospital to put in place centralized consent management, which will, I think, be an important step forward towards being clear about what kinds of things that patient is consenting to, including the use of biological samples in the future.
All right, thank you. Julio, did you have a question that you want to ask?
Yeah, absolutely. Thanks so much for the great presentation, David. The Faculty of Medicine has recently proposed a new initiative for data management and sharing called DataGora. So I wonder what you know about this initiative and whether the MUHC data warehouse will play any role.
Yes, and that goes to the slides I mentioned about alignment of what we're doing with the McGill sort of campus, as well as with the RI, and in fact, even with the Jewish and other hospitals in the McGill orbit, as well as other ones in Quebec. But specifically about DataGora, that's a initiative that's being led by Sylvain Baillet, who's the Associate Dean of Research in the Faculty of Medicine. It's focused a little more, I would say, on campus research. I think it's meant to encompass what's happening in the clinical space, but it's focused a little more on the basic science side of things. I've been involved in that process, and I'm a member of the Informatics Steering Committee at the Faculty of Medicine and Health Sciences. So we're trying to align with that. But I think what DataGora, it still is taking shape, I would say, is the bottom line for DataGora. Its focus, as I mentioned, across the span of life sciences through to clinical care. And so I think it's really important to have that perspective emerging on the campus at the same time as we're sort of, building up this perspective here at the clinical site of the MUHC. And, the biggest alignment I see there is around, kind of going back to the previous question, around issues of consent and coordination across McGill affiliated hospitals. So I think DataGora can be a really important pressure in that way to help align groups at, for example, the Jewish and McGill, LDI, RI, so that we try and put in place, as this new law comes in place, we have to put in place consent management mechanisms. Can we try and do that in a coordinated way that will really facilitate, getting more and larger studies across our sites, streamlining consent, even to the point of perhaps looking at things like data standards and making sure that we're organizing our data in a similar way across different sites to facilitate pooling of data or these federated data analyses. So I guess the bottom line is it's a little early to say exactly, what the connection will be, but we are progressing in close communication, and I think that's going to lead to efficiencies in terms of things like consent and data sharing in the future.
Amazing, thank you.
Thanks, David. Look, it's 8:30, but I'd like to push on with questions because there's a fair amount of them and the group seems to be holding despite the fact that we all go to the operating room. So if you don't mind, we'd just like to continue on. So maybe with Dr. Gilbert, and I see Dr. Stein and Dr. Barkin with hands up as well. And there are a few comments in the chat. So anyway, Dr. Gilbert, go ahead, please.
Dr. Buckeridge, that was excellent. And thank you to the surgical mission for bringing this information to us. A request for a tertiary care hospital like us, the fact that Cerner, the pathology database, is totally and utterly unapproachable and non-analyzable is very, very heartbreaking. Can you look into that, please? Because without pathology, we have to go by hand counts from tumor boards and all sorts of indirect way. That's my request, please.
Oh, and then I hear your request. And, I think you've raised a really important issue, which is that, it's not like we're the Mayo Clinic and we're our own independent organization. We are closely tied to the Ministry of Health and Social Services. And so there's a bit of challenge there in terms of how we update and change these sort of core systems. So the Cerner system is, is to be replaced, is in the process of being replaced. There are challenges there. And it's hard sometimes to think about the future when you're struggling to do day-to-day things like that. Those issues are very much on our, we're aware of them. The fundamental underlying systems are more of a kind of a process of change that's happening, driven by the ministry to some extent, particularly these centralized systems. And Dr. Barkin can probably tell you more about the challenges there. But I hear what you're saying. And one thing that we are going to try and do as we look towards a more sort of what comes after the warehouse is to look across different data systems and try to make sure that we're not missing key systems. And this would also go back to the question around biological samples, which again is relevant for pathology, how we link those back up with the rest of the data we have.
Thank you.
Thank you, David. Pro had a question about cost in the RAM-Q, but I think some of that was answered before. So I'm just going to go to Jeff because he had already asked a question in the chat, and then I'll go to you, Larry, if that's okay.
Sorry about that, Larry. Thanks a lot. David, I echo everyone. It's a great talk of a very, very complicated situation. At our hospital, we have a lot of data that are used. And really the ideal, what we would like is that any piece of data which is of big importance, I'll take an example, a diagnosis, should be leveraged. And the question that I have has to do with data quality and what gets brought in. We don't really have a policy or a mechanism regarding data leverage. Diagnoses currently come from medical records. They're basically finalized 4 months, 6 months after the patient's left hospital, but we need something that's more timely. Therefore, the question is, in OWARD, for example, we have tons of information which is leverageable. How should we go about basically trying to have a hierarchy of data so that we can start using the data that's being generated in a more timely way?
Oh, yeah, good point. And, we're not by any means fully exploiting the data we have. I think, I was trying to describe in the talk, I think in the end, the data warehouse we have was an important step forward, but if you look at sort of leading data, clinical data warehouses, there's some work to be done. And that work includes better understanding the quality of the data, adding value to the data, which I would include in that what you're saying, I think to some extent, being able to parse free text and extract structured data from that. So go through those OWARD notes and sort of categorize them in some way. Same thing with radiology, pathology reports, which are just sort of, free text right now. We need to be able to go through those and categorize those so we can use them more effectively. And also be able to map them to the common data models and terminologies so that, we can connect more in a sort of coherent way across these different types of data. So that's a big effort. And that's part of what we're trying to do in this roadmap for analytics and data management is lay out that work that has to be done, clarify where it is, and then try and get resources to do it. And so, the kind of work that you're describing in terms of quality is, part of that sort of a data science activity, if you will, but another part of that is actually engaging with the clinical teams that are entering the data that generate, the data centrally, the secondary data, or they were used for secondary uses. And I think it was, maybe you suggested, I think you made actually, Jeff, around, having people within the clinical teams that maybe are have a kind of responsibility there.
The data wranglers. I think that the point I wanted to make was exactly that, which is I think what we need is the same way that we have people who are specialists in ID and so on. If every clinical team was assigned a data wrangler, one could cover multiple teams. That is someone who would know the data, would be able to be essentially the data quality guru for multiple teams and allow the data that's generated, because a number of the old Word notes are actually structured and drop downs, not just free text, and allow that to get into the data warehouse. So you would have a data control at the source. I think having a data control once it's already in a database is much more complicated to do.
Completely agree, Jeff. Completely agree. And then that person can be part of, a quality improvement loop, essentially.
Absolutely, absolutely.
Yeah.
Thank you, Jeff. Larry, you've been patiently waiting. Thank you very much.
Thank you, Kevin.
Go ahead.
Yeah, David, that was a wonderful presentation. Thank you very, very much. I'm a radiologist, and as you know, we live in a sea of digital data. Probably more so than any other specialty out there, which makes artificial intelligence, which loves data, so useful in radiology in all aspects. I was just interested to know, in your data mining, do you have the radiology report? And if so, we have already implemented for many years now a word search function. Anywhere in the report, you can pick out any word in the report. That word may be La Chapelle. We can pick that out and see how many times he's done this. You can look up things like anastomotic leaks. Various ways you can set up a word search. So we have that implemented in our software at McGill. I don't know if that is yet available to you or whether you are using it, but I think certainly it would be interesting for you.
That's very interesting. Yeah, no, I will follow up on that for sure. We do in the warehouse, the radiology reports are there. We have done some work to look at actually de-identifying those. So using NLP and other methods to pull out mentions of, physician names and patient names and so on. But what you point out is really the next step, is to actually be able to pull out those structured data, what I would call, from that. So
yeah, good.
Definitely do not want to recreate the wheel there, and I would love to benefit from the work you've done. So I will follow up if you don't mind.
Perfect.
David, thank you. There are a few comments in the chat. I just one of them you've alluded to before, but there's a lot of interest in using video performance, video audio in the operating room, and trying to integrate that into your system, or not your system, but into the system. And then another one regarding, I guess, what Jeff was talking about, these data wranglers, Dr. Razik saying that it's been very informative, very useful in the trauma registry to have these people integrated into clinical teams. So that might be another area. I know a lot of clinical divisions, for example, have their own database, and then how do we take that database that we're collecting that's separate, that's already in our own storage, and how do we kind of put that in there? That's kind of a larger question, I guess, but something that maybe we need to think about going forward. David, look, I'd like to really thank you. We had up to 85 people, and you held most of those right up until now. So I think a lot of people have ongoing questions, and maybe people can communicate with you directly if they have other questions that are burning and might help them in their research. I don't know if there's a system like that. Would that be something we could lean on you for that, or? Oh
yeah, absolutely. I mean, unfortunately, I don't have the bandwidth to get involved in every research project, but I can certainly point people to the right resources if that's helpful. And I'd be happy to give updates at some point in the future too, as things move along.
Okay, that's great, Dave. Okay, well, on behalf of the department, I'd like to thank you for taking the time and giving us a great overview, great talk, and patiently answering all of our questions, of course. So
thank you very much.
Have a good day, and have a good day, everybody. Thank you very much.
Bye all.
Bye.